who is going to discuss the other adipocyte as an endocrine. Dr. Arun is the professor of endocrinology from Amrita Institute of Medical Science, Kochi. Office bearer, many professional bodies, state and national level. He has special interest in complications of diabetes, management of obesity and other endocrine disorders. Welcome, Dr. Arun.
So thank you for the kind introduction. After two clinical topics, we have perhaps got a topic which is not very much clinically oriented. I have to be honest and say that while preparing for this, I learned a lot because these are topics that we don't necessarily read a lot about. And also, I found it a bit of a struggle to put it into a structure because on one side, perhaps there are a lot of things happening in this area of, if I could call it, adipocyte physiology. However, there's very little direction. So it's in a state of flux. There's a lot of research going on, but nothing has materialized in the last, say, 2 decades or so. I'll tell you what I mean by that in the future slides. So we all know that adipose tissue is now recognized as the largest endocrine organ, and the metabolism of the adipose tissue impacts the whole body metabolism, and that is very well known. How it does is where we all have a problem in understanding, and that is because nobody is really sure. What is more and more clear now is that this is just not one endocrine organ which just secretes uniformly many of these adipocytokines. Adipocytokines being the products that come out. The adipose tissue in itself differ in the capacity to secrete adipocytokines. That is because there is a difference in the cellular composition of the adipocyte itself. So when you talk about adipose tissue, there are differential cells there which are producing different cytokines or hormones depending on where they are. And again, the slides that follow, we will discuss this a little bit. So it is a very dynamic tissue, and we would look at it in three ways. That is, looking at the control of nutritional intake. That is perhaps where there is most evidence in. And we know about the role of leptin and adiponectin, and we'll discuss that. So that is one area where the control of nutrition intake is an area of which is rapidly developing. The clinical use certainly has not come to the fore. We would hope that that will happen in the next couple of decades, perhaps. The second is its effect on insulin sensitivity, or to say on insulin resistance, and we'll discuss that as well. The third bit of it, which is its effect on inflammatory process as an inflammatory process mediator, is perhaps something which we will not discuss because of time. But clearly that the inflammation is something which is very much related to things like metabolic syndrome, and I'll touch upon that as well. So this is something which we know well. So I've been asked to talk on what is new, but to say what is new, we need to know what is old as well. So we all know that the brown adipose tissue, or BAT as we call it, is pretty much absent in adult humans. That is there in infants. It is more to do with thermogenesis that its role is. But in adults, the brown adipose tissue is much less, or in fact pretty much absent. Whereas the white adipose tissue, or what we call as a WAT, is the one that has got many roles. One of them being the mechanical role of protection and insulation. The second being its significant physiological function, and we'll touch upon that in the next slide. And then the endocrine function, which is what is of interest to us. So that is the white adipose tissue. But also remember about beige adipose tissue, which is a combination of brown and white, which is where there is some more evidence coming out, which what they say is that the white adipose tissue can differentiate over time in pockets, something like pockets of brown adipose tissue, which can happen due to differentiation of white adipose tissue. And they might have a different role to play in terms of the thermogenesis as well as in the secretory function. So clearly it's not as simple as we all have white adipose tissue, they secrete quite a lot of adipocytokines, and that's it. It's not. There seems to be differentiation that happens in this white adipose tissue. Now, if you look at the physiological functions of white adipose tissue, you can say that there are quite a lot. And this is something which has more and more emerged over the last few decades. But starting from its effect on body weight homeostasis, on glucose and lipid metabolism, on to vascular control, and very importantly, immunity. So clearly a lot of actions apart from just the appetite regulation and the nutritional aspects. So those are the physiological functions that the white adipose tissue has. So clearly when there is a change in white adipose tissue, that is, you are either having more or less, it is going to impact on a lot of bodily physiological functions. And I think that would be an extrapolation, but I think there is some evidence to suggest that. Now, what about the factors that are secreted by the white adipose tissue? Again, there are a number of factors, and I don't think in terms of time, we have time to go through everything, and I don't think you will, you will be bored to death if you go through all of those as well. So we will focus perhaps mostly on leptin and adiponectin, but there are so many others which might have physiological as well as pathological role in many of the disorders that we deal with. So in terms of secretory function, there are a few points that we need to note. I talked about the beige adipose tissue or the brown adipose tissue that develops in WAT. So what has been shown is that the WAT can be infiltrated with brown adipocytes expressing proteins, uncoupling proteins, and they have a role in thermogenesis. So clearly that is something which, rather than saying black and white, it looks as if even the white tissue has some amount of brown in it. Then there is also good evidence now that the visceral fat has high concentrations of interleukin and plasminogen activator inhibitor. So those are very, very important cytokines or adipocytokines, and there seems to be a preferential increase in those from the visceral fat. Whereas if you look at the subcutaneous tissue, there is a higher concentration of leptin and adiponectin secretion. So clearly there's a differential secretion from the different adipose tissue. Now, what is the importance of that? Clearly this will have an importance on one of our major players, which is the metabolic syndrome. So the metabolic syndrome, it has been shown that there is over-secretion of some of these, the PAI or TNF-alpha or visfatin, for example. So over-secretion of these has got a bad effect in our body in terms of metabolic syndrome. And there is a hyposecretion of perhaps one of the only good players in this, which is the adiponectin. So clearly these adipocytokines are contributing in ways that we don't fully know onto metabolic syndrome. Now, it is also somewhat well known that obesity is a state of chronic low-grade inflammation. So there is a low-grade inflammatory process which is happening, which is probably driven by adipocytokines. Now, what has also emerged in the last few years is the fact that macrophages, so many of the adipocytokines or the cytokines that we thought were being produced from adipocytes, there is now emerging evidence that these are actually from the macrophages. So these are macrophages in the endothelial cells within the adipose tissue. So it is not just the fat cells secreting all these adipocytokines. There seems to be a major role that the macrophages play. So that is another player onto all this. So if you have more of the macrophages or in the adipose tissue, they seem to produce a different sets of secretory function or hormones. So these are the list of, or at least a short list of the adipocytokines that are produced. As I said, I'll perhaps focus on one or two, not everything. And these are all the ones that there have been a lot of research on. But the one that would interest all of us, and we all perhaps know a little bit or more about, is the leptin. And the interest in leptin perhaps started in early 90s. So if you compare as new, perhaps all this is new because early 90s is not that long ago. So the obese gene was identified in 1994. In 1995, leptin was found out, was discovered. And then rapidly it progressed to finding out the fact, from Cambridge, Dr. Faruqi's studies that showed that you can reverse obesity due to genetic leptin deficiency by using recombinant leptin. So very quickly after identifying leptin, a recombinant leptin was found out, and they very quickly showed that in absolute leptin deficiency, which is a rare scenario, you can reverse obesity. So that is what excited people. So in 1995, we thought that we could straight away take off obesity away by giving leptin injections. So I think that was a very, very simplistic view of how to treat obesity. So we know it is a small peptide, leptin. It's a pre-inflammatory cytokine, and it's anorexogenic. So it will increase energy expenditure. That's as simple as it gets. So that's a very simplistic view of looking at leptin and saying, yeah, it causes anorexia, it will cause weight loss. But is that true? It's not. We know that because most of the studies haven't lived up to the promise. Now, what is also clear is that the leptin receptor is just not in the CNS. It is pretty much spread out everywhere in the body, including the peripheral tissues. So clearly, the action of leptin is just not on the adipocyte or on the energy metabolism. It is, if there are receptors all over the body, clearly these adipocytokines have actions all over the body. Now, what is also interesting is that there is a high circulating level of leptin in obese people and overfeeding. So all those actually increase the leptin levels. So the leptin level remains high in obesity. Unfortunately, supplemental injection of leptin has shown very limited success in terms of either reduction in body intake, in food intake or body weight. So clearly, whatever we had thought would work in terms of energy metabolism by giving leptin injection didn't work. So what did we do? So we introduced a word called leptin resistance. So it's easy, isn't it? When you use a lot of insulin and you have to use a lot of insulin, don't get control, it becomes insulin resistance. So if you have to use a lot of leptin and don't get an effect, then it becomes leptin resistance. But it's again not as simple as that, because we don't know how to define leptin resistance, and that is where the issue is. We'll come to that in the next few slides. But clearly this slide shows you that leptin has pleiotropic effects, multiple effects all over the body, and there is a lot of research around to show that its effect is just not on energy regulation, but on multiple other factors. Now, it is very safe to say that the leptin physiology is not well understood, and I think that I don't think anybody would argue against that, because you have studies showing both ways, in terms of leptin, although the action we know. So I think it is safe to conclude that a minimal level of leptin is needed to avoid massive obesity. So if you have absolute leptin deficiency, you end up with obesity, massive obesity. But so a minimal level of leptin is needed. However, increasing those levels further may not necessarily avoid obesity. So just by giving more and more of leptin doesn't mean that you will get the desired effect in terms of energy metabolism. And perhaps chronic lower than normal, so a lower than normal chronic levels may promote obesity. However, what is clear is that if you look through the studies, there is no human studies to suggest that higher leptin levels will suppress appetite or enhance energy expenditure. So just because the levels of leptin are low doesn't mean that you can inject people with leptin or give more of leptin and actually have an opposite effect or the desired effect. So clearly that is where the dilemma is. So we know the levels are low in obesity, but increasing it doesn't. There are really no studies to show that. Now what about leptin resistance? I mean, the analogy of insulin. I mean, there are lots of studies and lots of research around insulin and insulin resistance, and we know how insulin resistance works, or at least we think we know. However, when it comes to leptin, there is a huge problem, because we really don't know what is the physiological level of leptin and what are the biological actions in normal human beings. I think that is where the problem is with leptin. So what is the normal fluctuations, the normal level, what is the normal physiological functions, at what level what works? We don't know about that in leptin, which is why it is difficult to define leptin resistance. So why such apathy? Why have, even after 25 years of having had an adipocytokine in terms of leptin, after so many studies, we have not had the more clear answers. One can only speculate when it comes to this. I think one of the reasons would be the fact that very quickly after finding out the leptin, a recombinant leptin was found out. And the interest was really in translating onto clinical research and getting a clinical benefit. Unfortunately, what happens without enough scientific support, the studies on leptin, clinical studies on leptin happened in terms of treatment. However, when it failed, the interest was lost. So, unfortunately, the studies on obesity with leptin failed first up. Clearly, the science took a backstage. So now it is approved for administration in genetic leptin deficiency, as we know, as well as in leptin deficiency secondary to some of the rare forms of lipoatrophic diabetes. So that is where. So that's a small rare group. We see hardly any of these patients, unfortunately. Now there is more to all this with leptin. There is now emerging evidence that there is a lot of leptin brain adipose crosstalk. So clearly the sympathetic nervous system, which is an integral part, it's a adipose tissue, it's a richly innervated tissue, and the sympathetic nervous system is playing a major role in leptin production. So there is the effect of leptin on the brain might give us the answers as to how we proceed with using leptin in future. The other ones that I should touch upon in the last 3-4 minutes would be to look at adiponectin, which is the good one. There is a strong negative correlation between plasma adiponectin in the humans and fat mass. So the higher the level of adiponectin, the lower the fat mass, which is good. The higher adiponectin, less of type 2 diabetes, or the lower adiponectin and type 2 diabetes. And if you look at adiponectin, it ticks the boxes in terms of many metabolic advantages. So glucose uptake by skeletal tissues or skeletal muscles, improved insulin sensitivity, suppression of hepatic glucose output. So quite a lot of desired effects that comes with adiponectin. All these are studies that have come over the last 10-20 years. So that's good. But again, it's not as simple as just saying that it is a good one, because clearly there are different receptors in the body. Skeletal muscles have a different receptor to the liver, and that again shows that the effect of adiponectin in different body organs is different. However, the consensus at the moment, although there is a lot more work to be done, is that the central actions of leptin and adiponectin are perhaps those have reciprocal functions, and they might hold the key to our understanding of energy regulation. The other players, quite a lot of them, quickly to go through. One is the TNF-alpha, which is secreted mainly from the macrophages, from the stromal vascular fraction. They are increased in, the TNF-alpha is increased in obesity, and there have been some studies showing that a chronic administration of TNF-alpha can decrease uptake, at least in rat studies. So clearly they have some role to play in insulin resistance. So not a good one, but clearly that would be one of the players in terms of metabolic syndrome and atherosclerosis. The other one to mention about is the interleukin-6. Again, higher concentrations in visceral fat as compared to subcutaneous fat. And there have been studies to show that there is elevated levels of interleukin-6 with increased risk of CAD and atherosclerosis. So atherosclerosis and higher risk of, or higher levels of interleukin. Angiotensin, the one we know very well, is also expressed in the adipose tissue significantly, and they, as we very well know, have an effect on cardiovascular function in terms of hypertension, hemostasis. So clearly this shows that link with metabolic syndrome, hypertension, diabetes, and the different adipocytokines that are produced from the adipocytes. So there are very many which would act on different aspects of metabolism as well as on the vascular tone. Plasminogen activator inhibitor, another one which is expressed highly in the visceral fat, and seems to have a correlation with obesity and cardiovascular disease. Resistin, the one that has a very similar structure to that of adiponectin. There's quite a lot of interest around resistin, and that is because the administration of anti-resistant antibodies have shown to improve blood glucose control. So anti-resistin would have some effect on glucose sensitivity and glucose insulin sensitivity and glucose reduction. So to conclude, adipocytokines is far from a closed chapter. So I have perhaps only, it's a very futuristic talk. I have really not given you any new clinical information to take home with. Much of the research in this area has focused around leptin and adiponectin. I have not even touched things like visfatin and chimerin and so many of those adipocytokines, which all have shown promise in either as markers of cardiovascular disease. But to get this to the next level of clinical use is still far-fetched. Now, in terms of understanding of the metabolic syndrome, perhaps the low-grade inflammation within the adipose tissue could be one of the reasons for the dysregulation of adipocytokine production, and that is perhaps what causes metabolic syndrome. So identifying all these signaling pathways by which the adipocytokines would work will hopefully in future lead to newer therapies. Thank you.
Thank you, Doctor.